Afternoon. Welcome to the Davies Use Case webinar being presented by Parkland Health and Hospital System on OPAT. This is the Davies Award winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety. It's my pleasure to moderate the presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS integration, clinical decision support, and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence, pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of the organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcome resulting from health IT-enabled care delivery. It is my pleasure to welcome our speakers from Parkland Health and Hospital Systems, and I'll turn the presentation over to them to introduce themselves.
Microbial therapy program at Parkland. I'm an associate professor of infectious diseases at UT Southwestern. I also serve as a service chief of infectious diseases at Parkland, and I'm the medical director of our outpatient parenteral antimicrobial therapy clinic and infectious diseases ambulatory clinics at Parkland. Vaughn. I'm an associate professor of infectious diseases at the University of Texas Southwestern Medical Center. I also serve as the service chief of infectious diseases at Parkland and the medical director of outpatient parenteral antimicrobial therapy clinics and infectious diseases ambulatory clinics at Parkland.
I'm a clinical pharmacy specialist in infectious diseases with the infectious disease team here at Parkland. I joined Parkland about 2 years ago, and I serve as a dedicated pharmacist in the OPAT clinic as well as on the inpatient side. I have a special interest in process improvement through my training in Lean Six Sigma, and I'm happy to join you guys here today. So we'll start the presentation about our innovation in self-care, and this is through the voices of our patients.
Okay, make sure that you're from our patients firsthand their experience with this program that I'm going to be describing to you. In fact, the Self-Administered Outpatient Parenteral Antimicrobial Therapy, or SOPAT program, touches on numerous aspects of what's important to us as we think about where healthcare is today and where we're moving. This includes value-based care, quality improvement, population health focus, very much patient-centered care at the core of what we do. We incorporate patient safety, and we believe the success of the program really rests in patient engagement and patient empowerment as we transition them safely from hospital to home. In so doing, we are actively engaged in antimicrobial stewardship during this transition of care. None of this would be possible if not for the information technology innovations that help drive this process and the work of a talented multidisciplinary team to pursue this excellence as a continuum of care. So, provision of IV antibiotic therapy on at least 2 consecutive days without any intervening hospitalization. The goals are straightforward, and it is to allow patients to complete treatment safely and effectively in the comfort of their own home. In so doing, they can avoid the inconveniences, complications, and expense of a hospitalization. Through the model is schematically represented in this next slide. A given patient may present with an infection that is complex and requires a prolonged course of IV antimicrobial therapy. In the decision-making tree, we determine if they are medically stable, and if they are medically stable, is OPAT indicated or contraindicated? If it's contraindicated for a variety of reasons, they may end up having to finish their course in the hospital or another supervised setting. If OPAT is indicated, however, it's then our goal to select the appropriate setting for a particular patient to receive their care based on the availability of resources and the individual patient's needs. So what you'll see here in the next slide are various models of OPAT as they exist in the United States. Patients may be discharged home to receive IV antibiotics with the help of a home health nurse. They may be discharged to an outpatient infusion center to receive their IV antibiotic dose daily, or a nursing facility where they remain for the duration of their therapy to receive their IV antibiotics with assistance. What also is common is that they are resource intensive and require that the patient is insured or that we have the resources to be able to send them to one of these settings. What happens to one of our Parkland patients who is uninsured? An example of such a patient is an individual that we took care of many years ago, a 46-year-old African-American male who unfortunately experienced a motor vehicle accident. Post-operative infection occurred after he had infection of his prosthesis, and we determined that he would require up to 6 weeks of IV antibiotics to clear this infection. This gentleman did not have any history of drug use, and he was uninsured at the time that we took care of him. Patients with infections requiring long-term antibiotics typically receive concentrated diagnosis and prescription services in the first several days of their hospitalization, but then essentially remain in the hospital because, as the gentleman I described in the previous slide, are uninsured for essentially low-intensity needs and nothing more than an antimicrobial infusion. Insured patients, on the other hand, may be discharged early to home with nursing assistance or to a lower-cost nursing facility to complete treatment. This disparity causes a burden on safety net hospitals in particular and decreases the availability of acute beds for patients presenting with more severe needs. This is a schematic representation of what happens to those patients that are uninsured in the safety net system. As I mentioned before, the intensity of services is very steep in slope in that first couple of days that they're hospitalized, and then it plateaus off at a lower level simply for them to continue their antimicrobial infusions, complete a treatment course that may last 4 to 6 weeks. This poses a burden not only on the safety net hospitals in terms of judiciously using resources that are available to them, but also to individual patients who at that point are medically stable and would prefer to go home and resume their activities of daily living. The program is going to be described in detail, and from an overview, this is a picture of one of our transitional care nurses teaching our patients at the bedside how to self-administer their antibiotics. Developed in 2009 as an alternative for uninsured patients to complete long-term antibiotic therapy at home in a way that was comparable to services that were received in traditional settings, as I had shown you in the slide before. Teaching and competency assessment prior to being discharged from the hospital. Safely into a dedicated post-discharge OPAT clinic and followed weekly by nurses for PICC line care and at fixed intervals by physicians to assess clinical response to therapy. This is a PICC disciplinary team at the 2006 Gage Award reception that we received the award from the America's Essential Hospitals for Innovation. And some of how this program has been successful is that we've been able to incorporate multilingual, effective patient education material at the 4th grade health literacy level that was specific to our patient population and employ the teach-back method for bedside teaching to ensure sound comprehension of the important tasks they would have to partake in at home. Standardized core competency tools were then developed to test and record a patient's ability to self-administer IV antibiotics safely in the home setting. This is what I want to highlight here as we talk about transitions of care is that where you see these red asterisk checkpoints are essentially safety checkpoints that were built into this multidisciplinary process so that everyone from physician to case manager to nursing to pharmacy and then essentially the patient and family member themselves that may be helping the patient are able to ensure that the transition that occurs from hospital to home occurs in the safest and most effective manner possible. I'm now going to hand over the presentation to my colleague, Dr. Meng.
Thank you, Dr. So one of my primary roles here at Parkland includes continuous improvement of our OPAT program. And so I appreciate having the opportunity to share some of these frontline perspectives on how advances in information technology have consistently produced innovative improvements to our processes and how these ultimately have impacted the efficiency, safety, and positive outcomes generated by our program. So the Parkland OPAT model is heavily reliant on the multidisciplinary team, as we mentioned. And essentially, there are 3 phases to a successful OPAT consult. And these are evaluation, teaching, and transitions of care. So in our initial model, activating the OPAT process was typically done piecemeal by providers, and often components may be activated out of order. For example, consulting that vascular access team before the case manager has approved eligibility screening. So you could potentially have the placement of a long-term IV access in a patient who ultimately ended up being ineligible to participate in our home OPAT program. So what we did was develop an OPAT consult order set in Epic, which simultaneously places consults to each member of that multidisciplinary team. In fact, 100% of our inpatient consults are now activated through this pathway, drastically improving care coordination and helping to ensure the process is followed in the correct order, which is evaluation, teaching, transitions of care. One of our process improvements was the development of a pharmacist-driven clinical assessment tool. The elements of this tool, as you can see here, are used in 2 ways. First, they flow into our pre-populated note template. This serves as a discharge summary for the ID attendings who are following these patients up in the ID OPAT clinic. Second, each of these fields is actually just stored as a discrete data element. And so these are queryable data points, which we can use retrospectively to analyze pieces of our program. So some of the ways we have used this so far include looking at what are our most commonly prescribed IV antibiotics, what percentage of patients had formal ID consults, and what percentage of patients were discharged with self-administered home OPAT versus a more traditional model. And so in specifically leveraging an infectious disease trained pharmacist for this assessment, we're able to bypass the standard need of having a mandatory ID consult while still preserving both the quality and continuity of care. This criteria may seem quite basic that we're looking at when we talk about from our case management perspective, they are quintessential to the program's success. And I think anybody who works within an EMR recognizes that patient care documentation is not inherently uniform. And so this can make it difficult when you have numerous individuals performing a similar task without a uniform approach. And so the documentation can look very different. This was particularly true for our case managers, as their notes were 100% free text without a discernible formatting, which made it difficult for providers to digest at a glance. Whether their patient qualifies for the OPAT program, this format can be particularly tedious and error-prone, as they have to remember each of the eligibility criteria and then search for those eligibility criteria within the body of the note and make sure the patient still meets all of them. So building on the success that we had with the pharmacist assessment tool, we built the case management assessment tool, and it's a very similar concept. And so it's a step-by-step eligibility review. And what this does is records them as discrete data elements, as you saw here on the first slide. And so it assesses those very basic core competencies for a patient to participate in the OPAT program. And the note that is generated from that, as you can see here, it flows very well and is easy to digest as a provider. So that improved electronic eligibility and communication. Another fringe benefit, again, is that if we have a case manager working on this who's not our primary team case manager, they can very easily utilize this. So it improved and expanded access to our ability to utilize case managers. And again, with that pharmacist tool, same thing. These are all discrete data elements. And so we can use this data to retrospectively analyze our population to look at, for instance, what is the most common ineligibility reason for our patients? And can we target interventions to try and get those patients connected into care? So after and case manager evaluations, next comes our transitional care nursing team. And these are really the heavy lifters when it comes to teaching patients how to safely administer IV medications via gravity. And I think it's an important distinction to reiterate. In our program, we teach our patients to, mix their own drugs, hang their IVs on coat hangers, and count the drips to get a steady infusion rate, rather than using a more traditional model like home infusion pump, because it's not in our capabilities as a safety net hospital to provide those. When 2009, all of our program materials were printed and then manually distributed to individual patients. Bedside documenting the successful completion of OPAT teaching, and they would do this using a paper form. So after several days of teaching, that bedside nurse would then ultimately fax this documentation over to the clinic, where it would be further scanned into the patient's permanent medical record. And so this is a very manual process, required a lot of steps to be able to do it. You had to keep up with the piece of paper as well as, fax it to 3 different places before it made it into the patient's chart. And so this is a prime example of sort of an excessive documentation burden that we often place on our clinical nursing staff in practice today. So while some of our documentation is mission critical, others are overly burdensome and can detract focus from patient care. And this ultimately can create inefficiencies and even redundancies, which prevent nurses from operating at the top of their licensure. So we developed an electronic teaching tool. And so this, basically enabled us to record step-by-step these criteria and document them directly in Epic. And what this did, aside from eliminating the manual form, was also to improve communication and accessibility. Because now that this is in electronic format, providers can log into this sheet and see how their patients are progressing with OPAT teaching, and it helps them better coordinate those days of discharge. Additionally, we can also bring in our care coordination efforts, which allows not only our providers to track that teaching, but also our nurses, case managers, and other ancillary staff. And so, as I mentioned, in terms of education materials, we quickly realized that pictures can only go so far. And if we had a video, that would be a lot more translatable across a wider arrays of languages, because we have patients that speak not only English and Spanish, but we have patients from all over the world speaking dozens of languages. And so while we can have written materials available in a few languages, it really helps to be able to see this process happen and learn by demonstration. And so this led to the step-by-step creation of this demonstration video, which has been an enormous boon to our program. Here. Now, after we had this fantastic video, one of the technical challenges we immediately encountered is, how do we get this new media to the bedside and in a compatible format for patient consumption? solution to this problem was actually quite rudimentary. We essentially rolled a media cart into the patient's room, having one of those old CRT televisions and a VCR, and we left it there for them to play the video as many times as they wanted and to watch it. And so we have definitely been through several iterations of improvements since that process first began, but the latest one is very elegant and very streamlined. And essentially the way it works is any provider, pharmacist, or nurse is now able to order any educational video from our library, not just for OPAT, but for other things like diabetes education and how to give insulin, things like this. And so they can do this directly in Epic in multiple languages, and they can do it from anywhere in the hospital. And so once ordered, these videos are pushed to the patient's smart television, which is in every room, and they'll be prompted to watch it. And the medical team can then track and see how did they watch the video, did they complete the whole video, how many times have they watched it, and the assigned videos after they watch it remain available in their personal library for the patient to then rewatch them on demand anytime during their hospitalization. So they can continue learning even in the absence of a nurse directly teaching them at bedside. And so it's been quite effective for our self-teaching patients where the patient is the primary learner. It didn't always offer enough flexibility in educating caregivers who are learning how to administer and frequently were not on campus to receive nurse teaching as well as to rewatch the video on demand. And so in order to expand patient access to these educational materials and reduce these health disparities, we did two things. First, we uploaded both the video and our handouts to the main Parkland education website that can be accessed anywhere that someone has an internet connection. Second, we attempted to leverage the existing IT capabilities of our patients. So while we knew that our patient population may frequently lack access to a more traditional home computer, we did find that the majority of our patients own a smartphone. And we capitalized on this by creating a QR code, which linked directly to our educational video that was uploaded onto YouTube. And so in their training sessions, nurses show patients how to access this QR code using their smartphone. And then we put those QR codes on all the printed materials, not only including the discharge after visit summary, the paperwork that's handed to them by the OPAT nurses with their appointment on it, but as well, we put this QR code on every single bag of antibiotics that a patient receives, so that this is a safety checkpoint. It will ensure that all patients have access to this step-by-step live demonstration video 24/7, and to date, more than 1,400 unique users have accessed this video on YouTube. So as we know, oftentimes, the inpatient and outpatient worlds do not seamlessly communicate, and these are among the most vulnerable times for mistakes to occur in that transition of care. To ensure optimal patient safety, IT created a discharge order set for OPAT, where these two worlds more effectively communicate, ensuring that no patient would fall through the cracks. So this includes each of our IV antibiotics with built-in safety features, such as auto-routing these orders to the correct outpatient pharmacy so they aren't lost in electronic no man's land. And then in addition to the medications, it also encompasses everything the patient needs to safely administer their IV antibiotics at home. So this includes flushes, durable medical equipment and IV tubing, as well as laboratory monitoring. And one area where we significantly improved the transition of care process and worked to reduce inefficiencies in our process is in how we order supplies. And so previously supplies were completely ordered by freehand, and what this resulted in was providers would give patients the amount of supplies they felt that they needed. But oftentimes this resulted in a Goldilocks scenario where patients were provided either with an egregious amount of supplies or they could potentially run out of supplies midway through therapy and have to represent to the hospital to get additional supplies. So what we did was take the amount of DME that each patient would need, every supply that they would need, and turn it into an algorithmic calculation. And this ensures that as long as the flow sheet is filled out, that patient will automatically have the correct amount of supplies ordered for them every time. Of the transition of care, the informatics team in health analytics experts as well as our pharmacy experts actually were able to create some very specialized clinical interventions for our pharmacists to make on our patients. And so what this ended up being, this partnership ended up coalescing into were these value-driven stewardship transitions of care notes that our pharmacists could leave. And what this did was on the back end, whenever any one of these interventions was placed on a patient by a pharmacist, these were connected through literature-derived costs to the actual financial impact of what these interventions would be. And so we were able to use some of these interventions as we collated this data over the years to help justify part of the time and effort of the pharmacist to be dedicated towards the OPAT program. And so this is just to give you an idea. For example, one intervention that our pharmacist did last year, we were able to, with maybe about 5-minute phone call per day, 1 5-minute phone call per day, we were able to generate $300,000 in savings. So you're definitely really able to capture the value of some of your support staff for this program. Transitioning to the clinic for follow-up. Transition of care space, it's very important that we have a custom referral here that really helps to improve patient safety and maximize the efficient use of clinic resources. So for example, this algorithm, as you can see, there's a number of moving parts in it, but it really helps us to prioritize sicker patients or those with more serious indications to be prioritized to those critical earlier appointments. And our nurse navigator can use this tool as a form of decision support to ensure the right patient sees the right provider in the right time, and that we're a good stewardship team in terms of our clinic resources. And so there is variation in clinical outcomes that can occur despite best efforts. Some patients will inevitably be readmitted. And it is important that our team is re-involved in these cases to optimize their care and determine any additional needs. And so to facilitate this, we created a best practice alert, or a BPA, which fires for the inpatient provider anytime an OPAT patient is readmitted to the hospital. And this helps to improve the communication and care coordination for these particularly vulnerable patients. Additionally, we can then use the data analytics from these interventions to help improve our program by targeting what were those most frequent reasons for readmissions as potential process improvement projects. And so now I'm going to turn the microphone back over to Dr. Bhavan as we start talking about some of our performance as we've seen the outcomes in our program.
Thank you, Dr. Mang. So we wanted to see, after the first 4 years of administering the program, whether in fact our indigent patient population, often poorly educated and mostly non-English speaking, participating in the self-administered OPAT program, could actually administer their IV antibiotics at home as safely and effectively as traditionally accepted models of outpatient care available to those patients who have funding, otherwise known as hospital or healthcare-associated outpatient parenteral antimicrobial therapy, HOPAT. And in fact, when compared to their counterparts who had insurance and left the hospital with similar diagnoses over the same time period in the first 4 years of operation, the 30-day readmission rate for patients who left Parkland Hospital was in fact 47% lower for those patients who are uninsured and went through our OPAT program when compared to patients discharged with traditional HOPAT standard of care services. This equated to greater than 27,000 inpatient days that were avoided in the first 4 years of operation, and an approximate cost savings of $40 million for the hospital. Most importantly, we were able to improve resource utilization by freeing beds in a safety net setting for more acutely ill patients to be seen, while allowing our medically stable patients to engage in their own care at home. These in PLOS Medicine, December 2015. Other publications highlighting the work in the program, including a recent review in JAMA Viewpoint, as well as a New England Journal of Medicine Catalyst piece describing the program. And finally, Harvard Business Review, which most recently an article was focusing on our program, showed the value of teaching patients to administer their own care. We're definitely very interested in finding out what outcomes are important to our patients as we strive to achieve a patient-centered program. We found that our patients were satisfied with the ability to return to work earlier, with the ability to care for dependents at home. They were able to avoid high costs of hospitalization, which also led to satisfaction. They were able to complete their therapy safely in the comfort of their home versus being in the hospital, with minimal interruption of their activities of daily living. patients that were interviewed in that video that we presented earlier in this presentation. The elderly gentleman states, "I wanted independence to give myself antibiotics without having to follow the home health nurse's schedule." The younger gentleman to the right of your screen stated, "I wanted to be able to regain control in my life." So patient autonomy was a very important benefit of the program. At patient-centered outcomes and trying to measure or quantify these satisfaction scores, we conducted a survey with random sampling of patients over the first 4 years. And what we found was 85% of patients surveyed reported overall satisfaction. 8% of our patients reported satisfaction with the training that was received, and reported satisfaction with being able to return to work of the population of patients who were employed at the time given. We found our results did not vary based on gender, race, or age, or preferred language. Areas of research as we move forward with the program, we are going to be looking more intensely at collateral benefits of effective patient engagement through the OPAT model. We'll be doing this by looking at specific measures of patient activation, including the PAM scores or patient activation metric scores, disease markers such as diabetes and hypertension. In other words, if we can effectively engage our patients in one process successfully to self-administer their own antibiotics at home, does that translate to better diabetes control and hypertension control? We are collaborating with the Institute for Healthcare Improvement Center for Innovation to advance self-care initiatives nationally. The lessons learned over our almost 9-year experience now with the program. We found the OPAT model delivers care safely and effectively outside of the hospital. A multidisciplinary team approach with effective use of an order set and the EMR has been critical to successful implementation of this transition of care model. There has been physician ability discordance, which led us to do further research and understanding what are some of the barriers to create programs such as this where patients can self-administer IV therapy. We most recently received the Infectious Diseases Society of America's Clinical Practice Innovation Award. We've also received a Pharmacy Award for Innovative Collaborative Practice in Texas in 2016, and the Gage Award for Outstanding Achievements in Quality in 2016. None of this would be possible if we were not able to leverage HIT and see how it empowers patients to be engaged in their own care. And with the presentation, and we thank you for the opportunity to share our program with you.
And a great presentation. I just want to remind the viewers where to go find this recording and presentation and other Davies use case webinars and for Davies Award that is posted on the HIMSS Davies Award website at hims.org/Davies. And again, thank you so much.